Hi, so good evening, everyone. Can you hear me? Yes. Okay, so when Siva asked me to sit in the previous class, I thought he was talking about simple geometry. And to my horror, I realized it's symplectic geometry. Okay, I've never heard of that. So I'm pretty much in awe of all of you who do maths. I think I'm the only one in my family who veered away from engineering and maths from a father who was a professor of mathematics to medicine. So um, I'm going to probably talk about what my journey has been, and it's wonderful to see all of you, and all power to women. It's wonderful to see so many women who are interested in maths and statistics. And I was just thinking it would have been nice for my daughter to sit in to actually, because she was so scared of maths when she was in 10th grade, to actually see that maths is actually a lovely subject. So what I'm going to talk about, this is luckily, you guys don't have to take notes or anything. It's just like it's for entertainment value that you're going to be listening to me. So I'm really just going to talk about my journey as a woman scientist and basically the trials and tribulations we all go through and how really we can triumph despite all of it. And really, that's what all of you are. And as you go along, you will face some of these. So hopefully you can glean on some of these life experiences and make them your own. So when I started out, when I thought about medicine in my 12th grade in one Kendriya Vidyalaya in Hyderabad, I was the only one among my whole class of 100 who wanted to do medicine. Okay, everybody else wanted to do engineering. Well, I always wondered, am I doing the wrong thing? Am I doing the right thing? And now I think it has changed. Most people want to do biology rather than mathematics. But it was always, so I always sat with them during the breaks and solved all their problems along with them. But since then, my journey has been completely different. So my closet philosopher has always been Anne Frank. So I don't know if the younger generation knows who Anne Frank is. I realized to my horror, my daughter didn't know who Anne Frank was. I had to tell her about Anne Frank. So I think when we are struggling with all these philosophical questions in our life, at which path your career should take, you always wonder what you should do. So this one was something that I held close to me. Everyone inside of her is a piece of good news. The good news is that you don't know how great you can be, how much you can love, how much you can accomplish, and what your potential is. And it's amazing what a 15-year-old girl had such profound knowledge and wisdom while hiding away from the Nazis. So that was me as a 17-year-old. Actually, I was one of the youngest in my class, so I got bullied quite a bit. And this was the women's hostel that we had come to. I turned 17 and joined medical school, so it was not an easy journey. I think my mom was furious with my dad for sending me far away from home, but it has been truly a wonderful journey. So through my journey, I think once you leave school and you come to a college, that's when reality hits you hard because you're so used to being like the topper in your school. And then you come to this place and you say, oh, everybody else is a topper too. And so how do you actually navigate yourself through this? And this is something I think we face more and more. And I think it has moved from medical college now to 10th grade to 9th grade, and hopefully it won't go any lower. So navigating this, melee, and I know my children have gone through this as well, and trying to tell them that it doesn't matter, you are exceptional the way you are. And I think that's a very important lesson to learn. So we live in a world that constantly measures everything, right? Your talent, your character, your potential, your worth. Everything is like either a grade point average or some mark or your score or whatever it is. And even when you join a job, it's the same thing. So whether it's your schools or your colleges, they will be constantly ranking you, sorting you into one pile and selecting you based on something or the other, some personality traits or whatever it is. So I think it's important to understand that as you go through your career path, it's important to think tangentially. And that's why I like this quote, and this I used to make my daughter repeat after me because she had so much self-esteem issues when she was in school. So everybody is a genius, but if you judge a fish by its ability to climb a tree, it will spend its whole life believing it's stupid. Anybody knows who said this? Very good. Okay, so as you can see, it's been a journey for us. So now my foray into science or as a doctor began. Now, when you are a doctor, it's not just about the science, unfortunately. You know, it's been lovely to just sit in front and deal with all the science part of it, but unfortunately, there's art behind it, which means you're interacting with humans. So while you're dealing with science, you also have to interact with humans. So there is an art of science, and there is actually the science of medicine. So art and science have to collide where medicine is concerned, and sometimes that can be very, very tough. So these are the two individuals, and these are two of my bosses. One of my bosses, Dr. Dilip here, and he used to constantly tell us, I am teaching you the art of medicine. Dr. O.C. Abraham is teaching you the science of medicine. I never understood what that was. But he was a gentleman who sat in his outpatient department, and in his outpatient charts, he would have notes on the side about the patient's dog, what is the name of the pet dog, what is the name of his grandmother, what did they have, you know, and we would be like so annoyed because at the end of it, we'll still have to finish the notes and he'll be writing crap on the side. So I never really understood, but all this created a rapport, which his patients treasured him for. On the other hand, I had my other boss, my boss who talked about science and evidence and how you have to follow epidemiology and statistics, and everything has to be right. It has to be significant, and you have to go by p-values. You have to go by whatever risk ratios, etc. So marrying these two things doesn't come easily to a doctor, and this is something that we have to navigate. So yeah, this is tough. Okay, so we have to navigate this as a young medical student itself often, and then as you grow along your career path, it's again a different thing. Then on top of that, you've got children. Oh my God. So children, and those are my children when they were little, now they're big and irritating. But this is something that you do at the back while you're actually growing across in your career as a woman in science. And these are my parents, and as you grow, you also realize your parents are getting older and they need you much more in a different way. This is my department, and it's a huge department, and it's not easy to run a department. So when you all grow up and you basically become heads of department, you realize it's not so much just about the science anymore. Apart from the art of medicine, you're doing the science of medicine, then you're actually being an efficient HOD or a head of department, problem solver. All of these people, somehow you have to generate the salaries to actually make sure that they all stay back and do a good job. So being a researcher is not easy. So as a medical person or as a doctor in an academic field, somehow you have to be an absolutely fantastic doctor, you have to be a fantastic teacher, and you have to be a fantastic researcher. And believe me, it's not always easy. So I thought I'll kind of deal with two examples recently that we've had. So success stories and failures, okay? Or these are something that's happened in my life. And this was probably something that will give you, food for thought at a later date when you are navigating your own successes and your own failures. So, and how to stay cool, calm, and collected through all this. Believe me, it's not easy, and you will learn that. So one of the success stories, so it seems like a success, but I was tearing my hair out most of the time during this time. And I think the main thing was the COVID-19 pandemic. So in 2020, I still remember I was on a flight back from Malawi in Africa, and I saw it was somewhere around Jan 15th or so, and every Chinese worker on the aeroplane was wearing a mask. And we were all looking, and by mind you, were a bunch of doctors. We're all a bunch of doctors who had actually gone to a meeting in Malawi because of a study that we're doing in brain infections, and we're sitting there. And we're wondering, why are these people wearing masks? And we thought, it must be a Chinese thing. Okay, and then you come back, and then suddenly you hear, okay, there is some problem here, and people are actually, talking about this virus that has come up in Wuhan. And then this pandemonium breaks out everywhere. And I don't think all of us as a generation have lived through a pandemic. So I think this is something unique for all of us. We haven't lived through it. My parents obviously hadn't seen one till date. Lot of issues, lot of anxiety, medical uncertainty, unfamiliarity, leadership was terrible. Lots of experts are making goof ups. And people were talking about, okay, my risk versus community risk, and what are the more non-medical risks. And generally, the whole situation was absolutely out of control. So this was somehow after I came back from that, and I was thinking, okay, let's find out what is happening in the world. And this was in Jan 18th. I still remember meeting my hospital infection control officer and saying, okay, looks like we need to check out what's happening. And then we realized that there is this, the SARS-CoV-2 virus that has come up, and it used to be called novel coronavirus at that point in time. And we said, okay, let's release a first protocol on Jan 23rd, saying, don't worry, because there's no direct flights from Wuhan to Chennai. We are safe, we're okay. And that was stupidity, because we didn't realize we actually had medical students from Wuhan with us at that point in time. Anyway, the first, January 27th, the first imported case was actually discovered in Kerala, and we subsequently went on to have our first case in March. So what really happened at this point in time is, with the pandemic, we didn't realize what the potential of each person was. Everybody uniformly rose to the task, whether it was, somebody who's, a sweeper in a ward, a nurse, a doctor who's dealing with, surveillance of infections, or a doctor who's treating, and the surgeons who had basically were not operating at that point in time. They were willing to learn how to actually medically manage. We all went slightly crazy because we were the frontline people who were trying to educate people and constantly on the phone trying to deal with patients. So yeah, that was how I looked most of the time. I happened to be in charge of my hospital's COVID-19 preparedness program, and it was absolutely crazy. I don't think I slept very well for the first 6 months of the pandemic. So we also are a big hospital, and we see about 9,000 outpatients a day, and we have about 1.5 million patients at, basically overall we see about 1.5 million inpatients. So at a time, there's at least 2,500 patients admitted. So you can imagine the pandemonium, because you're trying to figure out how to see these patients while trying to remain safe, knowing that there's a pandemic coming. At that point in time, WHO had not declared it as a public health emergency of international concern. So we knew it was coming, but we didn't know how to not panic people and put in measures in place. It was not easy. We had to teach security guards to actually check whether the patient had fever, cough. So poor things will be sitting, okay, you have fever, do you have cough? If you have, they were actually separated out. So it was absolute havoc, but luckily we managed it. On top of that, we have 5 campuses. So we have the main campus, which is 2,500 beds. There's another campus, which is another 1,500. And we also have a secondary hospital, which is in Chittoor, which is a little away from us, 130 beds. We have another community hospital, which outreach centers, etc., which also caters to a fair degree of population. So what was lacking at that point in time? Of course, because we did not have clinical work, I think that is why we came up with a solution. So normally you don't really have time to think. You're going, you get up in the morning, you get ready, you go to your outpatients, you do your rounds, you see your consult, and you come back exhausted and you go to bed. You try and do research on the days you don't have too much to do. But this time, we actually luckily had time to think, to be able to plan, to be able to strategize, to be able to have teams which came together to think. So we had a triage team, and which, by the way, consisted of security officers, amazingly. And then we had our medical superintendent office, which is like a command center, which dealt with it. We had infection prevention control teams, environmental disinfection teams, amazing amount of engineering that we had to do to transform our hospitals to be safe environment for our healthcare workers. Then on top of that, no treatment, right? So we're wondering what to do. Patients are upset, faculty are upset, everybody's upset. They don't know what to do with the patient. So constant evidence synthesis, whatever is coming out, you're reading it, you're synthesizing it, and then presenting it in a format. So you can see this is some of the stuff that we did. you know, having physical distancing. It's not easy when you're seeing 9,000 patients a day. Disinfection, extra hand washing areas, universal masking, separate entry and exits, and closed areas even in the elevator. So it's not something that was easy. We had to modify our theaters because at that point in time, the theaters were not in a state. Normally, any theater, it's a laminar airflow, and we basically decide on a ratio of recirculated air versus fresh air. Obviously, it is more expensive to have more fresh air versus recirculate. So we had to switch the whole thing, which meant it was impossible and had to change to a lot of engineering controls. But it's amazing how much we all learned during that time. And of course, protocols galore. You can see here is one of for everything there was a protocol because people had to. We have 12,000 employees, so we needed to make sure that everybody knew what protocol to follow to keep themselves safe as well as the patients safe. So this was our command center, and every day we'd have like fancy, statistics up. Our medical record officers would deal with that, tell us the information. We had a system going where patients would come into casualty, had a way to follow. They had a pathway that was delineated for them to go into the wards, and then we had another team there who would take care of them. Remember, this was a time when patients were in the ward, but relatives were not there. So things like feeding, taking care of the patient, everything had to be done by doctors and the nurses. It was a nightmare, absolute nightmare. ICU capacity had to be suddenly escalated, and so we had wards. We had to suddenly take beds out of other wards and create ICU beds out of nowhere. Patients' relatives could not communicate with their patients. And that was a nightmare as well because they were upset and they were angry all the time. So we had to have a system of video conferencing. Thankfully, we have smartphones. Thank God for that. Can you imagine if there were no smartphones? So we had to figure out a way for the relatives to be able to talk to their patients. As usual, lots of protocols that they had to follow. On top of that, we had to keep our healthcare workers safe. So that was a major thing because we knew that there was a set, we had a pyramid where the infectious disease and the medical doctors were on top because they're the ones who knew how to manage the patients. Then you had a lower rung, which was your surgeons, then your postgraduate students, your medical students, and then so on and so forth, the nurses, etc. So keeping our healthcare workers safe was a huge priority, and that included not just doctors, it included nurses, thus class 4 workers, etc. Now, the biggest thing, I think all of you would have seen all the hue and cry in the media about masks. N95 masks, we did not have enough in our first 2 months. We had to figure out ways and means of buying masks that would still work for our patients. In January 2020, we were able to normally N95 masks are imported. India did not manufacture them. And most of these masks are actually imported. January, they stopped importing it. And so we did not actually have N95 masks. And we had to depend on a lot of these masks, which we were not sure about the quality. So if you notice, this was actually the original halyard that we were using. This is the 3M mask that normally I would have used for treating a patient with tuberculosis or a drug-resistant TB or a varicella or a measles or a rubella. But what we actually had available was something like this, and we were really worried about what exactly to do. So we said, okay, we have a challenge here. This was February, March. We have these substandard masks. We have to figure out a way to sterilize these masks and ensure that the filtration capacity was efficient. So this is my hospital infection control officer, amazing person, Malati. And we said, okay, we've got to figure out how to make these safe. So if we are re-sterilizing the mask, we need to figure out whether the fibers of the mask are adequate enough for us to be able to re-sterilize them. So this is the experiment that we put. So this is a mannequin here, which our biomedical engineering department, used to use it for something, I forget what. We took a nebulizer, we attached a mask there to this particular, you can see in the mannequin here. And then we let loose a nebulizer to see how many particles were actually getting in. This is a particle meter, this is the particle meter that was measuring the number of particles that were actually coming in. And what we found was horrifying. So we had the original halyard mask. That's what this was. And this is the mask that we were getting. So what we found was actually then the masks that were indigenous, available in India, were only actually 60% efficient compared to the masks that we used to be able to import. So we had to figure out a way of keeping our healthcare workers safe when you actually had a mask which did not really filter efficiently. And even if we took these masks alone, which we did not have enough of, we found that after the 8th cycle, there was a compromised fit. It was not fitting well, and doctors were being exposed to it. So this was all very exciting. Well, not exciting. It was anxiety provoking. But we used all of this to inform our policy. And the medical professionals are one group. These are doctors who are a cynical bunch. You cannot convince them of anything till you show them data. So what we had to do was convert everything into research. So till we kept on showing them real-time research, this is what we've done, you're safe, only on the 8th cycle it loses integrity, they wouldn't actually listen to us, and we'd get yelled at all the time saying, you're not keeping us safe, you need to find masks, we need to stop taking patients. All these kind of things were a huge problem for us. The other thing we did was to assess whether our PPE use was, or other personal protective equipment was working, was to do a contact tracing. So every healthcare worker who turned positive, actually even every patient who turned positive, but patient part of it was being handled mostly by the government. We just had to follow up. But the healthcare workers, we had to actually take care of. So we had to do a lot of risk assessment even before WHO came out with their guidelines. WHO came out with their guidelines in May, but we really had no time. We had to make our own guidelines. So lots of risk assessment questions we asked them. What were you doing when you got the infection? Did you talk to somebody else? How far were you from the person? What mask were you wearing? What were you doing? How long was your contact, and what was the distance? So this was the daily healthcare worker contacts of infected healthcare workers. So huge numbers that we were actually dealing with at any given time. And what we found to our delight was actually all the healthcare workers who got infected had got it from their household contacts. So their relatives got infected and they came and gave it to the healthcare. You can see here, this is the workplace contacts. So you can see here how gradually it declined. So the better they used our protocols, the less they became infected. So all of this was used to inform them, saying, please, for God's sake, use it, because it actually does protect you. So we came up eventually with the same thing, which eventually WHO actually put into a publication. So speaking with a coworker without mask, sharing the same workspace. So our accountants were sitting in the same room with no ventilation. They ended up, the whole accounts department ended up getting COVID. Having coffee and lunches. We are such social animals, but we just couldn't allow people to have coffee and lunches anymore. So we used to say, no, everybody comes in, you have a time, you finish your coffee, go. Have your lunch, go. And can you imagine trying to do this for all the healthcare workers? It's an absolute nightmare. This we fed into our quarantine advice, we fed into our exposure type to determine protocols. Then comes therapeutics, and this was even worse. You can see all the kind of headlines that there were. What I really love is this, because if you remember, we had some guidelines coming in which talked about ivermectin, and this was the thing that was brought out by CDC. You're not a horse. FDA warns against the use of animal dewormers for COVID-19 prevention. So we had a lot of data coming out in preprints, which was never seen before. None of it was peer reviewed. People were doing whatever they felt like, put it on the preprint server. And everybody was reading this. Everybody was a doctor. Everybody was an expert. And it was a nightmare. So how do we do this? So we actually had in March itself, we said, okay, let's have a group which will deal with rapid synthesis of evidence and make a rapid policy for us to use in our hospital. And that, in fact, became pretty famous over the country. And eventually, we were able to do it with the help of the Cochrane ID group. We were actually able to use meta-analysis and systematic reviews to be able to come up rapidly. This is about 150 physicians who came together as evidence synthesis teams, as expert teams, who were able to come up with the rapid living guidelines for the country. So this was really something heartening that came out of something that was just supposed to be for our own hospital. So this is a living synthesis, and this actually helped us to be able to train many, many young students in meta-analysis and systematic reviews. One interesting thing was lots of innovations. So you have, COVID-19 was a respiratory illness, but when you have a mask like this, okay, so you have a mask like this, it's called non-invasive ventilation. You put the mask on and you put the nebulizer, everything actually goes into the environment. So that meant all the doctors, all the nurses looking after that patient who was ill actually and needed it would actually be completely exposed. So we had to find ways and means of diminishing all this. So we did all kinds of things. We had this helmet NIV, which we made a helmet which the patient would be inside. We had intubation boxes. I don't think you can see it here, because intubation is one of those things which generate aerosols. So the doctors in the emergency would be the ones to get exposed. So we had to come up with indigenous ways of actually doing this. Even patients coming to register for an appointment, we actually had to make sheets and ensure that the healthcare workers were protected. We had to do this in the guise of science, because otherwise people wouldn't believe us. A lot of the routine activities that we used to do, like antimicrobial stewardship, all of the routine vaccination. By the way, it had a huge surge of diphtheria in 2022 because nobody got vaccinated. Children did not get vaccinated for 2 years. So huge surge of diphtheria, measles, and we're still kind of recovering from it. So 22, 23 were bad years for us in the medical field because of all the vaccine preventable diseases which came up. So we had to find indigenous ways of doing at least something. So we did this biomarker base. So we actually just had pharmacists who would go through a list of antimicrobials on the workstation and then call up and say, okay, cut this antimicrobial. You don't need it. We didn't need drug resistance in addition. A lot of patients did not get beds. So we had to find ways of managing them at home. And that again was an issue. So we had nurses who had guidelines, who had options where they would actually call up patients, and they had cutoffs which they would follow, ensuring the patients remain safe at home, and those who are not were immediately brought into the hospital. Vaccination came in Jan 2021. I think by September, the companies were already starting to manufacture vaccines. I think we did not really have an investment by the Indian government till about January, so which is why we had a delay in our vaccination. But of course, we are the vaccine capital of the world, so it was a matter of time before Serum Institute was able to repurpose a vaccine that was developed by AstraZeneca. But then people did not take it. Because why? Because the media was circulating all kinds of nonsense about how there was a chip in the vaccine and they're going to take all your knowledge away. They're going to change your RNA and DNA. They didn't realize RNA is not the same as DNA. They're going to change the kind of person you are. It was this absolute ridiculous stuff that was actually going around. So trying to get people to get vaccinated was another challenge. So we did something on side effects and perceptions, and we put in interventions in place saying, okay, you know what, these are your perceptions, now let's deal with those. Trying to tell them that your antibody response will go up if you take the vaccine, so had to show it to them that your antibody response has gone up. Please note that you're protected against a subsequent pandemic. This is again some of the work that we had done, showing that if you are vaccinated plus previously infected, you have far more protection versus just somebody who was unvaccinated and uninfected in the past. So a lot of things had to come up as a result of this. We were naively hoping that we had done with the most of it by July, August. So we set about putting in a model in place, like a geographic information surveillance of our district, saying we will predict it, we will map this out, and we will predict the next one, so we will be prepared. Unfortunately, we didn't realize that Delta wave would hit us sooner than we expected, so all this work was to naught, and March, April came on so soon, and it was so much worse than the original ancestral strain that we didn't actually have time to deal with this. So basically, we took all the challenges we had, and as you know, a lot of the hospitals were not allowed to test for COVID till very late. I think till March end, most of the hospitals could not test, and only a select government institutions could test. But I think there was a lot of hue and cry, and by April, May onwards, till May actually, a lot of people could not test for COVID. So that just added to the confusion. So lot of challenges, as I've outlined, and we had to find ways to make them into strengths. I'm not really going to go into that. So that is, I actually consider that a success story. Do you think it's a success story? I think it is. And it was actually one of the few times when we actually genuinely felt that we had achieved something despite insurmountable odds. Now, no story or journey is complete without some story of failure, right? Because obviously we are failing all the time. So one of the problems that we encounter, so I don't really want to call it a failure. It's too defeatist. So I'm going to talk about it as an ongoing problem that we're dealing with, okay? So I know all of you know about drug-resistant pathogens, bacteria. We are the capital of the world. Now, if you look at whatever bacteria you want to look, India is the darkest. So this is, I even forget what this is, but this must be, carbapenem-resistant Acinetobacter baumannii. Okay, you don't need to know what that is, but basically is a deadly pathogen which causes a pneumonia when you're on a ventilator, and 80% of the drugs are actually resistant in this particular pathogen. So you can see here, there you go, India's dark red. Then this is carbapenem-resistant Klebsiella pneumoniae. Carbapenem is like the last resort antibiotic for most, and we are there very much, okay? And you can see here we're at the 50 to 60% end of the spectrum, and we all know that we are going to have a huge problem in much later. And if you read one of the landmark papers by O'Neill, I think he's a statistician, if I'm not mistaken, and he predicted that basically Asia is probably going to have the biggest number of deaths due to antimicrobial resistance, and it's going to be one of the biggest pandemics that we may not be able to save ourselves from. So in 2050, it's going to cause as many deaths as actually cancer or other things. It's going to overtake everything that we know of. So I'm an infectious disease doctor, so obviously I have to do something about it. So how do bacteria emerge resistant? So this is susceptible bacteria, and they undergo mutations. You get newer resistant bacteria, but the bacteria are far cleverer than human beings. So what do? They define other ways of getting it. So they get this plasmids or extracircular DNAs here, or you have these resistant genes which it can acquire from others, and you end up with like massively resistant bacteria. So what do? What happens when you take a population? So you have, say, a pneumonia, and you've got bacteria inside that are causing the pneumonia. Most of the bacteria are good, nice bacteria, which will respond to the antibiotics you're giving. But there is actually one bacteria among this colony of bacteria that is actually resistant, but it's just overcome by all these wild type bacteria that, nothing happens. But you give them antibiotics, what happens is you're killing all the good bacteria, and your resistant bacteria are going to predominate. Now, this bacteria is going to stay in your body for 6 months to a year. So God forbid, you have another infection, you're going to actually have an antimicrobial resistant infection, right? So what do we have to do? We have to ensure that we do not use antimicrobials unless absolutely necessary. So bacteria give the most thoughtful gifts, and we end up with these in our gut, in our respiratory tract, in our wherever, for a long time. So when they actually map the drivers of AMR, so this is an article which talks about it. You can see here, human antimicrobial misuse is one of the largest reasons for development of antimicrobial resistance. So that's why that's important. Now, is it easy? No, it's not. It requires leadership commitment, accountability, pharmacy expertise. Now, if you ask a surgeon to give cancer drugs, he will say, okay, that's not my area of expertise. You ask him about antibiotics, he'll say, yeah, of course, I can use it, okay? So that is the reason antibiotics, everybody, why my mother thinks she's an expert. Like each time I have a URI, I'm like, she calls me and says, why aren't you taking antibiotics? I'm like, Ma, it's a viral infection, I don't need antibiotics. No, I've taken it, it works really well, you should go and take some azithromycin, okay? So even my mother thinks that she's an expert. So obviously, other doctors are going to think they're experts. So that is a problem that we're dealing with, and these are what we consider as the core elements of antimicrobial stewardship. pharmacy expertise, action, tracking, reporting, and education. So yes, this is another reason why I look like this. And so what do we do? So when you're expecting, you go to the administration and you say, I want to do stewardship. You go there all, bright-eyed and bushy-tailed and looking. This is what you're expecting. What you really get is this, because the administration wants to give you very little, but wants you to do a lot of work, right? So they just basically want you to do something for national accreditation. They want to make sure that you're able to do a lot of stuff with very few people. And that, again, is a huge problem. So this is one of the interventions that we put in a while ago, where we had to demonstrate to, this is before I actually even got pharmacists, because they wouldn't give us pharmacists. So we did this study where we said, okay, if you do an intensive antimicrobial stewardship in the ICUs, you will actually, so I had to employ people, pay them, find funding for them, a pharmacist, a hospital epidemiologist, another doctor, and we actually showed there was no change in de-escalation and mortality, nothing happened, but we were able to reduce antibiotics to a fair extent. Required a huge team. It was not a small team. We came up with that, went to the admin, and they said, show us the money. So she said, give us a business case. So we're thinking, okay, how can we generate a business case? Lots of data on that. So we said, okay, let's count it. No use, because the business case did not really work, because actually, for some reason, that year we had a lot of patients who were sicker. So really, a business case didn't work. So what did we do? We fell back on them and emotionally blackmailed them. This is our mission. This is our vision. We should be doing what is right. And it worked to a certain degree. And now I actually have about 2 pharmacists who the institution actually pays for. Educating other doctors, educating other healthcare workers with regard to stewardship is not easy, and this is something that we had to do. So training doctors who are leaders in their field in antimicrobial stewardship often is a huge challenge. But it is a multidisciplinary team. We do need a data analyst, so we collect a lot of data to be able to tell people. My pharmacist, amazing, and what I found when I started this, there was no training for pharmacists in infectious diseases or AMSP. So about 5 years ago, we started this fellowship program for antimicrobial stewardship for clinical pharmacists, and it's generated a wealth of well-trained pharmacists who are amazing at what they do. Then coming to the doctors, to actually the departments. That is what they actually want. They want you to show proof. They want you to show evidence that what you're doing actually works, what you're doing is actually important, right? So you go back, you're seeing their patients with them, coming back, saying that, okay, look, this patient, you can actually reduce the antibiotics. Even if you reduce like 2 days of antibiotics, we're actually celebrating here, because it means 2 days of a period where you can be drug-resistant bacteria-free. So lots of effort, lots of work it takes, because you have a lot of infections, a lot of clinical syndromes, a lot of doctors that you have to convince. So it's not really easy. All of this needs science. They're not going to believe you, so you need science. And a lot of this was actually done by my amazing group of pharmacists and young doctors that I have working with me. Now, when I'm trying to do something, I'm imagining something beautiful, that beautiful little painting that you see on the left side of this girl with that wonderful butterfly. But really, what you get at the end of it is something looking like that, right? So with things saying butterfly and stick figure. So really, it's not easy to apply whatever we are doing, and it takes a lot of work. So what do? You default to some low-hanging fruits, things you can do easily. Okay? So intervention activities, which you would know are actually going to be beneficial for the hospital in the long term. So you find something that's easy and quick, which has the maximum yield, and you put that into place. Okay, so then overcoming barriers. Always, there are going to be those set of people who are the most difficult to handle. They're usually the oldest and the wisest doctors, and they can be very difficult to actually convince. So this is a nice cartoon in NHS. The NHS believes in a carrot and a stick approach to motivation. So what's the carrot? No stick, okay? But trying to do that is easier said than done, and it's often very difficult. So what do? We use the Big Bang Theory approach, okay? So Really, we're using positive reinforcements. I don't know how many of you have seen Big Bang Theory? Anybody? All of you? Great. So I'm sure you've seen this episode. And this is what we actually do. So using positive reinforcement to correct what we consider correct behavior. So this is what we do all the time as stewardship. Tracking a lot of data that's generated because they need data. All of these is collected by our pharmacists who actually put them into graphs. And then we take this reporting to our administrators who then eventually look at that data and then decide on whether to give us more people or allow us to continue doing this because it also needs an input from the side of the department that we're generating it from. So unless they act on the data that we provide or help work with us with the data we provide, the whole exercise that we do is completely meaningless. So not only do we generate data, we take the data back to the administration to tell us, okay, we have administrative permission. We take the data, go to the department, show them, have a consensus meeting and arrive on some amount of compromise. Sometimes it can be actually quite difficult as well. Okay? So with that, what we do is once we've arrived on a compromise, we have a system of electronic alerts which we put in. So this is what we do. Some of it can be very difficult because sometimes it's difficult patients and they won't actually listen to you, which means infectious disease doctors have to go and put in a long consult with references and everything. But sometimes it may actually just be easy. We just message them on our hospital system or put in electronic alerts when they log into the system. So they know that the alert will not go away till they have actually done that action. So all this you can imagine can be quite annoying, but we are like little mosquitoes who are hovering around you and making sure that you actually do that. Lots of audits. It's very, very important that we gain peer support, we gain confidence. And yeah, this is like we're lifting on 3. Actually, the patient was not lifted onto the OR table. They were not working in tandem, so the patient fell off. You can't see the patient was fallen off onto the OR table. So it's important. So these are all the kind of meetings that we have to do. This is just a snapshot of what we've done in 2019. But in addition, we also have to educate constantly. So constant reinforcement, because memories are fickle. So we have to keep convincing them that what we're doing is worthwhile. So we have to do it differently for administrators, differently for physicians or prescribers, and differently for pharmacists and nurses. So really, why do we do all this despite all this? Because we have to be the change that we want to see. And so this is the reason that we go ahead and do it. And but who wants change? Everybody wants change. Who wants to change? Not that easy. So it's very, very difficult. So we believe that if you want to have some change, you actually have to be the change. Okay, so I'll end with this. I'll just show you some pictures. So this is what we do. This is the various programs that we run for WHO and other people. This is, I don't know if you know it, but we have an antibiotic awareness week. And WHO says go blue, so you will see a lot of blue buildings around. But basically, this is what it's all about. We have marathons, we have public meetings. The whole buildings are lit blue, and that really helps to actually. So I'll end with this. This is the moral of my story. Life is difficult, but remember you're amazing and stronger than you actually know. So I'll end with that. And this is my favorite song, by the way, in case you all want to listen to it at some point in time. So thank you.